Hi, David Rosenberg here for the Psychopharmacology Institute. In this CAP, or Child and Adolescent Psychiatry Smart Take, we'll take a look at a possible treatment option for pediatric patients with schizophrenia or bipolar 1 disorder. Now, I don't have to tell you that the need is huge. This remains an understudied area. It remains a challenge. And although the current treatment options are helpful, they clearly remain insufficient, and all too many children, adolescents, and their families suffer a great deal when treatment is only partially effective, if it's not effective, if patients prove to be treatment resistant. So the need is huge as the current treatment options remain insufficient. I'm not bashing the treatment options. We use them and they can be very effective in many patients, but there are risks and benefits. There are side effects. There are patients who don't respond, who can't tolerate the medicine. And so more work is needed. The first line medication treatment, the atypical antipsychotics, can also have significant side effects. And we know that youth are especially vulnerable to these side effects and much more exquisitely sensitive to experiencing the side effects. Cariprazine is an interesting compound to study as it's a D3 preferring D3, D2, and 5-HT1A receptor partial agonist that's FDA approved to treat adults with schizophrenia and bipolar 1 disorder, manic, mixed, or depressed episodes. So this open-label study enrolled 50 pediatric patients with schizophrenia or bipolar disorder, 13 to 17 years of age, with patients assigned to either slow titration of cariprazine over 6 weeks from 1.5 milligrams to 4 milligrams per day, or fast titration to 4.5 milligrams per day. So what did they find? The good news is that cariprazine was safe, well tolerated in pediatric patients with schizophrenia or bipolar 1 disorder. The pharmacokinetic profile of cariprazine was consistent in pediatric and adult patients with schizophrenia or bipolar 1 disorder. And that's interesting because that's not always the case with psychotropic medicines in pediatric versus adult patients. Cariprazine was associated with no significant changes in prolactin levels. And since D2 receptor antagonism is associated with increased prolactin levels, cariprazine being a D3 preferring D3, D2 receptor partial agonist, which may be associated with its favorable effects in terms of prolactin and metabolic levels, makes it appealing potentially. There was a greater incidence of weight gain in 10 to 12-year-olds treated with cariprazine than in the 13 to 17-year-olds. Some adverse events, such as increased transient diastolic blood pressure, were observed more commonly in the fast titration versus slow titration phase. And this may be associated with the long-standing principle in child and adolescent psychiatry to start low and go slow to enhance tolerability. In my experience, I've seen far too many times where a good medication choice is ruined because of being too aggressive, starting too high, or increasing the dose too rapidly and not giving the child or adolescent time to become tolerant to the medicine. One exciting finding that, if replicated, could be huge and underscores the need for future controlled study was not only was there improvement in symptoms in pediatric patients with schizophrenia or bipolar 1 disorder patients treated with cariprazine, but this improvement was maintained even during the follow-up period when cariprazine was discontinued. Now, some of the patients did restart their previous medicines, but these findings are actually consistent with prior findings in adults with schizophrenia, where patients who discontinued cariprazine had delayed schizophrenia relapse compared to adults with schizophrenia who discontinued other medicines used to treat schizophrenia. And it's been suggested this may be due to the longer half-life of didesmethylcariprazine, one of the active metabolites of cariprazine, coupled with the fact that this active metabolite has been shown to occupy D2 and D3 receptors for 4 weeks after the last dose. The half-life of D-S-methylcariprazine in pediatric patients is also similar to the half-life in adult patients, so the sustained improvement with cariprazine observed in adults may also be seen in pediatric patients. Now, I hasten to say this is an open-label study, first look, so controlled studies are needed, but they're definitely merited, and if this is replicated, this would be a very important finding. The bottom line, this is a very promising area, not yet ready for prime time, but clinicians treating pediatric patients with schizophrenia and bipolar I disorder should definitely keep this on their radar, with controlled randomized clinical trials in pediatric patients clearly being warranted. Very exciting times ahead.